Greetings, my name is Dawn. I'm one of the nurse practitioners here at Presbyterian St. Luke Medical Center, and we're here today for our Ortho 1 total joint replacement. Our goal for today is to prepare you for your total joint replacement. We're going to go a little bit over the surgery. We'll discuss the orthopedic team, who includes the physicians, the surgeons and the hospitalists, physician assistants, nurse practitioners and nursing, physical and occupational therapy, and case management. Our goal is to provide excellent care and education while you're a patient on our unit. Some of the goals for your recovery: we'd like to get you home within a day or two. We need you mobilizing, up and walking. We need to teach you how to do all this safely. We're going to work on pain management, and we're going to educate you every step of the way. So what is total joint surgery? Normally, total joint replacement is done to relieve the pain and disability from arthritis or even trauma. The surgery consists of replacing the diseased and painful joint surfaces with metal, plastic, or ceramic components shaped to allow motion. Your surgeon decides what one is the best fit for you. These are examples of what a diseased hip joint looks like and why you would need hip surgery, as well as when the cartilage finally wears out in the knee. So that's what worn out cartilage looks like. These are what the replacements look like under X-ray. If you'll notice on the hip one, on the left-hand side, that's what the hip replacement does. If you'll see on the right how they've taken out the native bone, the native ball, and then they've replaced it with that component. The knee, even though it says it's right, it's on your screen, it's the left one. That's what the total knee looks like compared to the other knee, which is still the native knee. These are a couple examples of the replacements. If you'll notice the porous surface on the hip replacement as well as the knee, it's kind of that gray, speckly looking stuff. They've determined that the porous surface makes your native bone grow into these implants. It makes them much stronger and makes them last much longer. So that's the new way of doing these replacements. This is an example of what shoulder arthritis and arthritis cuff with rotator cuff deficiency looks like. The shoulder finally gets that arthritis, your bone on bone, and it just plain wears out, or your rotator cuff has finally given up. This is an example. The one on the left is when it's a total shoulder replacement. That's when your rotator cuff is still good. The one on the right is a reverse total shoulder replacement when they had to do the rotator cuff as well. So how can you plan for your surgery? We want to make sure your home is ready for your recovery. I always recommend people remove the rugs that may slide, that may trip on walkers. Make sure any small furniture, ottomans, or step stools are out of the way. Be careful with any pets or small children that might trip you when you get home with your walker. Just make sure everybody's aware that you're going to be moving a little bit slower. Make sure you have transportation after surgery. You cannot drive until the surgeon tells you to, so make sure you have somebody that can pick you up on the day of your discharge. Make sure your home is stocked with medication, food, personal care items, ice. Ice works great on those total knees as well as the shoulders. I always tell people, make sure you have plenty of toilet paper. You don't want to have to stop at Target on your way home just to pick up things. So make sure you've got your home stocked. Make sure you have comfortable shoes, rubber shoes, no flip-flops, and comfortable loose clothes to wear home. Right now, with it being summer, you can wear shorts. Even in the winter, sometimes people wear shorts just because they're easy to put on for the drive home. Make sure 4 weeks before you have no dental appointments, or just check with the office. Have a good support team available during your recovery period. I always tell people you don't have to have somebody 24/7 unless you do have that opportunity, but you do need somebody there for at least the first couple days just to make sure you're getting around and doing fine at home. Preparing for your surgery, you're going to, obviously you've met your orthopedic surgeon. You're going to go through our primary care clinic or your own primary care provider. So you'll need to obtain that medical clearance from your doctor. And then the surgeon would say, yep, let's go, let's get this done. You're going to undergo any necessary testing and the MRSA screening. In the office, they should give you some HIPAA Cleanse antibacterial cleansing soap. There should be a handout with you with instructions to do it 4 days prior to the surgery, and then the final day, the day of surgery. Make sure your personal belongings and notebooks are packed. I always tell people, bring a notebook and a pencil and write down any questions. When the surgeons and the PAs around first thing in the morning, oftentimes they wake you up out of a sound sleep and you have questions and they're in and out and you didn't even have a chance to ask the question. So make sure you write things down. Bring only the necessities. You don't need to bring any valuables. A lot of people bring their cell phone. That's fine. Don't forget your charger. They bring their iPads or their Kindles, things like that. We do have a Walgreens in the building across from the hospital that can fill prescriptions and deliver them to the room. Make sure you have some way for a copay if you have that, cash or a credit card, if you have a copay with your prescriptions. You don't need to bring any of your medications with you to the hospital unless you've been directed to do so, but we do carry almost every imaginable home medication that you might need. Bring a list of your medications, the prescribed, over-the-counter, herbal, that make sure it has the name of the medication, the dose, the time you take it, and your pharmacy information. If you have a copy of a living will or advanced directives or durable power of attorney, you're welcome to bring those with you, and we'll just keep a copy in your chart. The night before, no food after midnight. You should be given an Ensure pre-surgery drink, and you need to finish that drink 4 hours before your scheduled surgery time. So if your surgery is scheduled at 8 a.m., you need to drink that drink by 4 a.m. You need to have it finished. Stay well hydrated the day before surgery. Make sure you're drinking plenty of water because you're going to be nothing to eat or drink for quite a few hours after that. Take any medications as directed by your primary care physician or the PAT clinic if you've gone through there prior to your surgery. Get some rest. It's going to be a busy couple days after surgery. You're going to come in through the Surgery Admissions Welcome Center. You need to arrive 2 hours before your scheduled surgery time. So I tell people it's like the airport. You're going to be there 2 hours before your flight. So again, if your surgery is scheduled at 8 a.m., you need to be at the Surgery Admissions at 6 a.m. or earlier if your surgeon or the nurse navigator tells you to. There's a place there for the family and friends to wait for you. They've got Wi-Fi, coffee, things like that. They will admit you there. They'll enter all your information. Then they will take you to pre-op holding where you will meet your surgeon there and the anesthesiologist. The nursing will put an IV in you, put you in the gown, then you'll go off to the operating room. When you're finished there, you'll go to our post-anesthesia care unit or our recovery unit PACU. In the PACU, they're going to check your vital signs, meaning your blood pressure, your heart rate, your oxygen level, make sure your pain is controlled, make sure you're awake enough to come to the orthopedic unit. And this is where the nurses and the nurse practitioners take over. The nurses will orient you to your hospital room. They'll show you how to use your call light, the buttons on the bed, the telephone, and they'll just tell you about the monitoring systems. You will come up with a little pulse ox on your finger that glows red. You'll have a blood pressure cuff, and all those will be hooked up to the monitor in the room. If your oxygen drops, things will start beeping. So that's what those monitoring systems are. The nursing staff will do a bedside report first thing in the morning with the outgoing staff, and then first thing in the evening with the outgoing and incoming staff. Nurse leaders round on you every day. In every room there's a communication board, a giant whiteboard, where you're welcome to write questions. They write the name that you like to be called. Your nurses will put their name on there, your surgeon's name, and every shift the nurses will go over your plan of care. What would you like to see happen today? Nurse practitioners, there's 4 of us, sometimes 2 in the morning, anywhere from 1 to 2 in the evening. We round as needed to manage any issues that may arise, whether your pain medications aren't working, if you've got low blood pressure, home medications, we're there for you. And then we also help with the coordination of care, so we do some rounding with the rest of the team to make sure your discharge plans are in order and we've got what we need to get you discharged. We do this Monday through Friday. Pain management, we'll work very diligently on your pain. The nurses will go by a pain scale. The nurse practitioners generally prefer how can we manage your pain so you can get up and walk and move and do your exercises. There's various pain management techniques. They reassess your pain every 1 to 2 hours, and there are a lot of different types of pain medications. Those are all managed by the surgical team and the nurse practitioners. Right now you've got chronic pain with this knee or this hip or this shoulder. It's been getting worse and worse over time. Right after surgery, you're going to have acute pain, meaning it's sharp and it's brand new, but the acute pain goes away. Whereas chronic pain gets worse, acute pain gets better. So we have different types of pain management choices. The surgeon and the anesthesiologist will choose what kind of blocks they want. We always try to offer an anti-inflammatory pain medication, whether it's an NSAID, an ibuprofen, Tylenol. We try to use minimal narcotic pain, spasm medication, because when they've done that surgery, they've cut those skin and then the muscle, moved them over, and that causes those muscles to spasm. So the opioids and their narcotics don't work on the spasms, but we have several types of spasm medications that work very well for those. Ice works great on knees, works great on shoulders. Positioning, sometimes you just need a little boost in bed to help the hip pain after hip surgery. And then any kind of relaxation channels we have, or just watching TV. For shoulders, they do a nerve block and sometimes a pain catheter if the surgeon feels that might help. The nurses will assist you with activities of daily living. They're going to help you get up to the bathroom. They're going to help you wash your face, brush your teeth, get you dressed when it's time to go. They're going to round on you every 1 to 2 hours. For meals, we have room service, so you just call a number and the room service will bring food to your, whatever you choose to order, to your room. We do encourage everybody to get out of bed to a chair for the meals. We usually let you have one meal in bed, but then we like you to get up just because that gets you in a routine of when you go home. You're going to have to sit and get up for your meals at home as well. Lab will come around every morning about 4:30 if the labs are ordered. The reason it's so early is we like to have the results in by the time the surgeon's around so they can see how everything's looking. The nurses are going to discuss any current and new medication with you. Anytime they give you a new medication, they're going to discuss the action and the side effects it may have. After surgery, you are at increased risk for falls. I know it feels good. You've got that new knee, you've got that new hip, but we really need you to call for assistance because once you get up, maybe that knee is a little weaker than you expected. We just don't want anybody to fall, and that's what we're here for. We're here to help you, and we're happy to assist you. Physical and occupational therapy. The role of physical therapy is to reinforce your weight-bearing status and to teach you how to walk safely with a walker and crutches. They'll teach you how to safely navigate steps if you need to use them. They always teach you how to do steps because even if you don't have steps at home, there are steps out in the world, a curb or into a store. They're going to teach you how to independently get out of bed safely, and chairs. They'll teach you how to get in and out of chairs safely. They will reinforce your precautions every time they work with you. They'll work on range of motion and strengthenings, and they'll promote independence with your exercises. How will you be able to do these exercises at home? The role of occupational therapy, they will go over more in depth the activities of daily living. They'll teach you how to groom at the sink, the best way to put your walker while you're standing there. Toileting, they'll teach you how to get up and off the toilet after your hip and after your knee surgery. They'll help you teach you the best way to get dressed, how to get your socks on, things like that. The showering tub transfers and the best way to do that. They'll teach you how to get in and out of the car safely, and they'll teach you safety every step of the way. If you have a shoulder, they're going to teach you how to manage that sling and the exercises you can do for your shoulders when you first get home. They also are going to reinforce your precautions every day they work with you. Physical and occupational therapy will evaluate and get you moving the day of surgery or the day after, depending on what time you arrive at the orthopedic unit. They'll evaluate to see what does your home setup look like, how's your functional status, what do you need assist with to get your goals for discharge. Physical therapy will see you 2 sessions daily except on Sunday, then it's 1 session. Occupational therapy will see you 1 session a day. Oftentimes they both go in together and see you at the same time. They don't set specific times for therapy because they arrange your therapy around your pain medication and your meals. So this is an example of what an anterior hip surgery looks like compared to a posterior hip. The anterior hip is an incision on the front side. The posterior is an incision toward the back side. Anterior hip precautions are just avoid extremes of motion, like no yoga, be cautious getting on a bicycle or a horse. Generally, there's not a whole lot of other precautions with the anterior hip. Posterior hip has a few more precautions for the first 3 to 6 months. No bending past 90 degrees, no crossing your legs, no turning the operated leg inward, just like these examples show. So if you drop something, you shouldn't bend down and get it like that lady is doing. No crossing your legs, and keep your legs straight with your shoulders. Oftentimes, if you have a posterior hip replacement, you'll come up with the abduction box in place. It's just a reminder not to cross your legs. This is an example of some of the equipment you might need after your joint replacement. They recommend a front wheel walker for almost everybody. Crutches, oftentimes if you already have a walker, you need crutches. A reacher is good, especially if you've had posterior hip and you drop something. It's easier to pick up something with a reacher. Same with the sock aid. If you have that posterior hip, a sock aid helps get your sock on. A shower chair is nice if you can get one, just because sometimes you get weak in the shower with the warm water and washing your hair and things like that. It's not mandatory, but it's nice to have. You'll need a cane for shoulder patients because you're not able to use a walker with your shoulder. And then sometimes the raised toilet seat is nice with the knees and the hips, especially if you have an older home that has the lower toilets. This is an example of what a shoulder surgery sling would look like. Total shoulder has, again, they'll wear this pillow with the bolster that they'll put on you in the operating room. The occupational therapy will teach you how to put it on and how to make it comfortable for you. You will not be allowed to rotate this shoulder outward for 6 weeks to allow those muscles to heal. And they will teach you on passive shoulder motion. The next part of the orthopedic team is case management. Case management works on discharge planning, whether it's to home or acute rehab, a subacute rehab or skilled nursing facility, if you might need any home health care, and if you need any outpatient therapy that a prescription will be needed, and the surgeons will provide that prescription. So they work, like I said, they work on the discharge planning. Their goal is for everybody to go home after surgery, either the day after surgery or the next day. The outpatient therapy for knees and shoulders, again, the prescription will be provided by the surgeon. So you can, if you have a walker or crutches at home and you want to bring them in with you, that's fine. We do provide a walker or crutches while you're here from our physical therapy department. But if you have a walker that you have and you want to make sure it's fitted correctly, go ahead and bring it to the hospital and physical therapy can make sure that it's the right height for you. Make sure you have somebody to drive you home. Remember, you cannot drive yourself home. So make sure you've determined before you have surgery who can pick you up and transport you home. Your case managers will meet with you if you have discharge needs, and they also participate in the daily patient safety rounds, and your needs are discussed at that time as well. You can also request a visit at any time. So what's the road to home? How to get you safely out of here? Again, you have to be mobilizing, you have to be up walking, you have to be able to safely transfer in and out of bed, in and out of a chair. You have to be able to walk safely with that new walker or crutches. Any drains you may have will be removed before discharge. Sometimes hip surgeries have a drain and sometimes shoulder surgeries have a drain. Dressings will be changed to a silver-based dressing that can stay on for 7 to 10 days. And then everybody needs to work on their incentive spirometer. If you don't come in on oxygen, we don't want you to have to go out on oxygen. So please take your incentive spirometer home with you. Continue using it for at least 10 days after your surgery, just to help keep those lungs clear. We also want to prevent deep vein thrombosis. How we prevent that is usually we have sequential compression devices, SCDs. They're a green squeezer that you've got on your leg. Some surgeons, like the TED hose, they usually send you on some kind of pill anticoagulant, whether it's aspirin or whatever they choose. We work on dorsiflexion and plantar flexion. When you do ankle circles with your feet and point your toe and stretch your feet, all that helps prevent DVTs. We rarely use bladder catheters anymore. It's too great of a risk for infection. Pain meds can be very constipating, so we make sure that you have laxatives and stool softeners. You have to be able to pee before you go home, but you don't necessarily have to have a bowel movement before you go home. But you absolutely have to be able to empty your bladder before you're allowed to go home. Then the orthopedic team will determine when it's safe for you to be discharged. Again, no driving. Remember, you need a ride home. Any supplies, a new walker, or any other type of equipment will be given to you, and any new medications. The nurses will go over all your discharge teaching, the new medications, any medication changes. They'll discuss again your equipment and any ambulation techniques. And the staff will escort you to your car. So thank you very much for listening in on the Total Joint class. If you have any questions, the phone number listed here belongs to the nurse practitioner office. Feel free to call at any time, and I will get back to you as soon as I can with any answers to any questions you may have. Thanks again for choosing Presbyterian St. Luke Medical Center for your Total Joint.